Hi, this is Austin Nakatsuka, and I'm about to show you my very quick and simple way that I use to lift a dislocated lens in the eye. So here we have an eye that looks like it doesn't have a lens in there. It looks aphakic because we can't see any lens that's in there, so it seems like there's nothing there to lift up or to get. But actually there is a lens in this eye, and what's happening is this lens is hanging down by a few zonules, and when the eye is coaxial like this with the patient lying supine, it's actually hanging back by a few zonules, and it's very hard to see. But you can see it at the slit lamp when the patient is sitting up. And we have to go and get that lens and lift it up into the anterior chamber for me to get it safely and not drop it to the back of the eye. And so I'm going to show you my really quick technique to do that. And here I'm slowing down things because I want you to see here, I'm making him shift his eye, and you can see that lens wiggling back and forth temporally on the side there. And it is basically, there it is, attached by a few zonules temporally. And you see it flap like that, just like a trap door. And it's just being held by those few zonules, so we got to lift that up. And you can reach down and grab it with an instrument, but I've dropped many a lens that way. So here I am taking a 30 gauge needle, and I just bend it at 90 degrees like that, and I'm inserting it in the pars plana about 3.5 to 4 millimeters from the limbus, and I just poke right into the sclera, and you can see that needle is behind the lens, and it lifts it right up just like that, right into the position I need it so that I can grasp it and hold it up safely. And I leave the needle in there and use the two hands, one with the needle and one with the grasper, to lift it up into the anterior chamber so that the haptics are in the anterior chamber, and then it's secured. And then it looks really good there. I mean, you can barely see the haptics there. You almost want to leave it. But no, that's a single piece lens that's um, in the anterior chamber. It's not meant to be there. So I'm going ahead and opening this up, and I open it up a little larger because I'm going to use a three-piece lens to sclerofixated lens, and I just can pull that right out. Yes, you can cut that in half and reduce the incision size there, but I don't want to risk doing that and dropping the pieces of the lens that we just lifted up so nicely with the 30 gauge needle. So that is my technique of using a quick 30 gauge needle to just lift the lens up through the pars plana posteriorly and lift that lens up where I need it to be. And it's so quick and easy that there's barely any of that in the video. And and the nice thing about it is it's a 30 gauge needle, so it's really thin. So I really don't worry about it having to put a suture or anything like that. I don't worry about it leaking. I've never really seen it leak. I don't need to put a suture there. I just pull it right out. There's very little bleeding. You can barely see the spot where I put it in. And that was it. I just lifted it right on out. And barely leaves a mark there. So I really like using that technique to go ahead and rescue a lens that is held on by a few zonules, but not very, it's in a precarious position. And here we're just doing the Yamane technique here. I'm using the AR40 lens with, otherwise known as a sensor lens, with PMMA haptics. And of course we're using a 30 gauge TSK needle here to do the sclerotomies for the Yamane technique. I use a different 30 gauge needle than the one I use to insert into the sclera, just because I want a nice, fresh, sharp needle when I insert into the sclera there each time. So I don't want it to be dulled by the previous time I used it to lift up the other lens. And that centers really nicely. Everything looks really good. It's very similar to my other videos. But the main thing I just wanted to show here was how to lift that dislocated lens, because quite frankly, that's the hardest part of this whole surgery. Once you learn how to do the Yamane technique, the haptic flange sclerofixated technique, and you get good at it, then you can do this part, as you can see, within a couple minutes. But lifting that lens up without dropping the pieces, that's the hard part, and that can be tricky. But it doesn't have to be hard if you use this technique, which I like very much. And everything looked good in the end. Patient did well, no hypotony or anything. Lens looks great. Thank you again for your time, and hopefully that taught you something, and it's a technique that I really like to use. Thanks again.